Okay, welcome everyone to I think this is the fifth of our SHA mini masterclasses. Thanks for finding the time to join us today. Today we are joined by Dr. Andrew Booth, who's going to be talking about the question of who, not if, achieving real impact through qualitative systematic reviews. I've known Andrew for quite a long time now. He gave me my first job in SHA in 2003, and Andy Tattersall, who organises this masterclass series, started probably about a year or a year and a half before me. So we've both known Andrew for a long time. He was really one of the founding members of SHA in 1994 and set up the Information Resources section and the Information Service at SHA, expanding it from just the one person and a room to a proper library and information specialist service, which currently sort of averages between 10 and 12 staff at any one time. He's probably best known these days as a systematic review methodologist. Since 1995, he's been teaching in the area of systematic reviewing on our Masters in Public Health and also the Masters in Health Informatics. And he's very well known for his work with the Cochrane collaboration. In particular, he's a co-convener for the International Cochrane Collaboration's Qualitative and Implementation Research Methods Group, a founder member of the Cochrane Information Retrieval Methods Group, and a member of the Cochrane Rapid Reviews Group and Cochrane Trainers Network. He's also a member of the Information Specialists Group for both HTAI and Intertask. It's my pleasure to introduce him today as our fifth speaker in the series. So I'm just going to switch over from my slides to his, and then Andrew will be able to start. Okay, over to you, Andrew.
Thank you, Claire, and thanks for a lovely introduction. And it just so happens that this will be my 26 years in SHA this week, so thank you for joining us this lunchtime. So as you can detect from the title that I've given, I'm looking broadly at the issue of impact and really reflecting on a sort of personal journey as we've seen impact move from the impact factor, the IF of the title, as indicated here by the logo of Web of Science, the authoritative journal citation reports. But on the right-hand side, we have a video that was released by the World Health Organization to celebrate their program of work called Driving Impact in Every Country. And this came out in December, and in it they commented that even as we are responding to one public health event or crisis, we are also working to support countries in meeting the health needs of their populations, strengthening their system, and planning for the unexpected. And certainly those are very timely words at the moment. And then they go on to say, with the pandemic dominating the headlines now, it is easy to forget that WHO is simultaneously taking on multiple other health threats, both ancient and modern. And of course, many of us are drawn to our involvement in health services research, health information management, through a commitment and a desire to see the health situation in our various countries and across the globe, to see that improved and to see that change. Now, just if you permit me a brief moment of recollection, this was a milestone for me. This was my first systematic review published as a health technology assessment report, now under the National Institute of Health Research, back in 1997. It was on the topic of neonatal screening for inborn errors of metabolism. And the reason why I'm highlighting it today is that this was the first health technology assessment report that I know of that had a specific chapter, in this case, on qualitative research. And it wasn't a synthesis, it certainly wouldn't claim to be done systematically, but briefly it was almost a structured meander through some of the issues raised by qualitative research with regard to the phenomenon of parents witnessing their children having a needle to extract blood being used to draw blood from their newborn's heel. And so, as you notice the trajectory here, It's achieved 298 citations, which sounds like an awful lot. It certainly puts it in my top 20 of publications, but that's not quite so much if you think that that's little more than 15 citations a year. So this is how impact is traditionally considered. Since those days, and you can see this quite timely on the graph here, we've seen a rise and rise of qualitative evidence syntheses. I know it's very popular to use Medline graphs to show the growth of research in general, but really it is quite a dramatic growth in qualitative evidence synthesis, and it's been catalogued sort of more precisely, again using a very crude measure, but you can see here from 1995, so not far different from that neonatal screening report, there were just 10 new publications that could be counted as qualitative metasynthesis appearing a year, and by 2015 that number has been estimated to be just over 3,250, and that number's going up all the time. In my role as the person who maintains the Cochrane Qualitative and Implementation Methods Register, I get alerts every week of at least 100 potential qualitative syntheses, although obviously not all of those are correctly indexed or identified by my search strategy. I'm sure I should confess that. Accompanied with this, we see a recognition of the political significance of qualitative evidence. So on the left-hand side here, we have a recent editorial in the Bulletin of the World Health Organization by Langlois et al. And on the right-hand side, a colleague and collaborator of mine here at SHAR, Chris Carroll, he wrote on the impact of qualitative evidence within the guideline process of NICE in the UK. And certainly we can see that not only is the activity increasing, but the influence and impact of these syntheses are increasing as well. They're becoming more center stage to the evidence synthesis process. And I've been privileged amongst many international collaborators to work with two groups in particular, with the Cochrane Qualitative and Implementation Methods Group. I've been associated with that for about 15 years, I would think, and more recently with Grade CIRQUAL, which is a process for grading recommendations produced from qualitative research. And these have, if you like, opened up opportunities for me to get involved in methodology work around the development of qualitative evidence synthesis methods. And it's taken a while, but after much campaigning within Britain, at last, a few years ago, the Cochrane Library accepted its first ever qualitative evidence synthesis review. So up to that point, the qualitative evidence had been admitted into effectiveness reviews, but in a supporting role, not as a synthesis in its own right. But this editorial in the Cochrane Library heralded the appearance of the first standalone qualitative evidence synthesis. Now, I say standalone, but in fact it was one of a pair that it complemented the corresponding effectiveness review. So we see these sort of two pillars, if you like, supporting decision making around not only do things work, but also are they acceptable. And colleagues of mine who've been heavily involved in the qualitative evidence synthesis activity, and particularly working for the World Health Organization, predating my own involvement, in fact, therefore posed the question just a couple of years ago, are we entering a new era for qualitative research? And they described the role of qualitative evidence in supporting guideline development by the World Health Organization. And very influential on me was this particular review by Megan Boren and colleagues. Megan was employed by the World Health Organization. She remains a founder member of the Great Circle group, and she looked at facilitators and barriers to facility-based delivery in low and middle income countries. So what affects whether women decide to access delivery services to support them giving birth when they're living in low and middle income countries. And this also featured the grade circle methods as well. So it was one of the first exemplars, if you like, of grade circle methods. And so through my involvement in grade circle, I became aware of this particular review. And I thought, well, what a challenging task to try and summarize evidence for the whole world within a limited time scale. You've got all of the countries that qualify as being low and middle income countries, and you can only get a fraction of those countries represented in the literature, and only a fraction of the literature. And so I thought, well, how does possible depth complement the breadth offered by these very broad WHO reviews? So I set an assignment to our students, and here are three of the students that I've collaborated with. In the first of these, Brenda chose to repeat Megan Boren's review, but looking only at Kenya, and indeed only looking at rural Kenya. And she was able to find many more studies than Megan and her team had been able to identify. She was obviously focusing on a single country. She was able to access resources that perhaps wouldn't be the mainstream resources for a general search of the nature that Megan and team had done. So it's by no means a criticism of the WHO work. It's just to illustrate really how, along with the need to cover a broad country situation, there is a requirement to be able to offer nuanced understandings of what's going on in a particular country. And then a couple of years later, in a following cohort, two students independently, Suleiman and Chukwudi, both chose to do a similar review for Nigeria as their systematic review assignment for my module, and have completed that and done it completely independently. They thought that there was some potential in pooling the efforts that they have put, and approached me to see if I'd be interested in turning that into a review. So I'm going to focus on Brenda because her time was a bit earlier than Suleiman and Chukwudi, but just to say that Suleiman and Chukwudi have a manuscript now that is currently approaching a publication. But in Linda or Sarang's case, she focused on rural Kenya. The WHO review had found 4 Kenyan studies, but that included rural Kenyan studies, and rural and urban, and only 2 of those were rural. So only 2 out of the 4 Kenyan studies would have met her criteria. For her mini assignment, we asked students to look at about half a dozen studies. And sure enough, she identified 4 further studies. So she had 2 from the WHO review and a total of 6 in all. And then when she completed her assignment, been assessed and gained a good mark, she collaborated with me, and as I would hope as a signed up information professional, I was able to find more studies. And so between the 2 of us, we now had a total of 14 studies that all met the criteria of rural Kenya, 14 compared with the 2 WHO. And we worked together and Sarang submitted a paper to midwifery, and on the back of the work that she did with me, she obtained a reviewer post at the University of Newcastle, and then the domestic circumstances required that she move, and she contacted me just last month to say that on the back of the work we'd done together, she was being able to register for her own PhD. So this is a nice instance of working together, students and faculty together, building on work from the World Health Organization, but adding value to it by adding a specific country-based slant to it. And as I mentioned, Suleiman and Quidi were also doing something similar for Nigeria, just a little bit behind. And so this gave us a unique opportunity. We had a World Health Organization review done by Megan. We had a published Kenyan review by Brenda. And we had a manuscript, so all the work had been done, it just hadn't been published, from the two Nigerian collaborators. And so we presented at the Cochrane colloquium. I presented on the students' behalf, which looked at the trade-off between doing country-specific qualitative syntheses. And just to throw in one point, because at the moment there's a lot of concern with COVID about the quality of published journal articles, particularly around preprints, of course. But the question there about whether we're harvesting pearls or grit was a reflection that although we'd found more studies and they had valid data in them, some of those were published in what some people would regard as questionable journals, predatory journals. So were we opening up the richness of our qualitative data, but at the expense perhaps of the quality of it? So that was the issue that we chose to focus. And subsequently, the four of us wrote up our experience across these two country-specific reviews in an article published in the Journal of Advanced Nursing. So on the back of such work, I got invited to a WHO expert seminar of methodologists that were asked to look at the requirements of complex interventions in terms of synthesis processes. So how could the guidelines that WHO produce be taking advantage of methodological developments to be able to handle complex interventions? Because obviously facility-based delivery is a complex intervention. Many of the other focuses of WHO are also important complex interventions. So we took part in two seminars where we developed guidance and was part of a subgroup that was developing the guidance for qualitative and mixed methods synthesis. We identified that as well as a need for those papers, there was also a need to look at how context was handled in systematic reviews, because of course context is absolutely critical when you're looking at how a complex intervention achieves its effect. And so the paper that I produced under this mini-series sponsored by the World Health Organization looked at what tools are available to help you handle context in systematic reviews and guidelines. And just a couple points here that you might find interesting. I identified three what I call fallacies, three false assumptions that you might make from reading a statement based on qualitative evidence. So there's the universal fallacy that you read a statement that's supported by qualitative evidence that you think might apply everywhere. There's fallacies that relate to the focus of the question and also to the availability of evidence. So I would encourage you to have a look at that in particular. And then four ways that we identified one could handle these findings, these recommendations, to avoid those fallacies. So by making an exception of areas that you know are not covered by the findings, by actually nominating exclusively countries from which the evidence comes from, by saying what the circumstances under which the evidence would not apply, and also showing hypotheses where you characterize the recommendations according to where you think they're most likely to apply, even if you haven't got evidence for every single country in that group. So some interesting thinking going on there, and my interest in context has spun off more recently. I'm pleased to welcome my new PhD student, one of a number of excellent students I have at the moment. He's in Sun, who is specifically going to look at how you can develop qualitative approaches to complex health interventions within the context of syntheses, particularly international syntheses. And I'm very pleased that I'm actually working with another former PhD student of mine from York, the University of York, who is now a colleague, Dr. Katie Swan, who again pursued an interest in complexity and review methods with myself and the supervisor over at university. So, yeah. Sorry, was that you, Luke? Oh, sorry, I just thought someone was saying those problems with sound or something. Okay, I'll continue. Sorry about that. And the other paper that I produced under the banner of the BMJ Global Health mini-series was specifically on the use of questions in qualitative evidence synthesis. It looked at all the question frameworks that currently exist, and it identified some missing elements. So the question framework should include context, it should include perspective, it should include considerations of timing and place, and of course it should be appropriate to qualitative data. And none of the existing frameworks satisfied those four criteria. And so I proposed this one, which you can see is linked to my own review question, and this is perspective. With C variously there in brackets or in a copyright symbol to indicate that that's a sort of optional element of the formulation. So the idea behind developing perspective, and it's fully described in that particular paper, is to be able to accommodate complex interventions with some of the areas of variability that you may want to factor into your specification of the review and subsequently into your search. Of course, I wouldn't pretend to be one of the first to get involved in WHO guidelines. I would refer you to another mini-series, this time in health research policy, by some of my colleagues and indeed a fellow PhD examiner of mine, Sue Down, where they wrote a series on the use of qualitative research in guidelines, so how to inform guideline scope, how to inform evidence to decision frameworks, and how to develop the implementation considerations. So this work was all going on, and we received an invitation to be involved in guideline production ourselves. And here at SHA with colleagues such as Chris Carroll, I was involved in a WHO guideline where we provided the qualitative evidence for the topic of Zika virus transmission. So reminding you of the statement on impact I made earlier, that more than just COVID is still going on in the world and needs to be addressed. So that was in December of last year, so coming around an anniversary. The work that I've just highlighted from the mini-series shows which points of the decision-making process of the evidence to decision framework the qualitative research can inform, and that was our task alongside an American team who looked at the effectiveness evidence. And this is nicely displayed, this infographic here by Simon Lewin, which shows the impact of qualitative evidence synthesis on the clinical guideline development making process. And for the Zika review, which has just been published only last week, we found a shortage of evidence on attitudes towards breastfeeding for Zika, and unsurprisingly perhaps, all the 6 articles we found were from Brazil. And so in order to answer questions, because guidelines are about decision support, not just knowledge support, we broadened it to look at other conditions where mothers may have difficulties in feeding their babies, other forms of encephalopathies. I knew I'd have trouble with that one, but as characterized by congenital Zika syndrome. So we've published this article, and so it's rather unusual as a review because it has a clear focus on Zika, but then it has a number of analogous conditions where the experience of mothers is still felt to be relevant to those who are nursing babies with Zika. And without going into too much detail, because we'd encourage you to read it, download it, and cite it as in line with my impact note here. So we found that the indirect evidence was really useful, particularly in the form of training programs, for example, for infants with cerebral palsy, for example. Those courses would be very suitable in developing training for mothers who are having feeding difficulties with their children. And so, taking us back to the impact theme of this presentation, that synthesis has directly informed WHO infant feeding guidelines. And on the back of that, we've more recently done a review on ready-to-use therapeutic foods, so alternatives to breastfeeding when it's not possible to breastfeed, but these that relate to having less than 50% of their proteins coming from milk products. I'd just like to flag up the complexity here, that it might seem a fairly straightforward question, but actually there are 3 issues going on here. Are the breast milk substitutes, are they acceptable? Can they be locally produced? And what are the implications of non-milk in terms of, for example, the availability of foodstuffs and that sort of thing? So we found this to be a very much a complex problem, not just a complex intervention. And we used the circle method for assessing it. I've used a bit of a color scheme here, but that isn't mandatory for use of circle, but just to show the different domains and the overall conclusion. And for a guideline committee, we produced an alternative to the report, which had the full circle assessments. We wanted to get some slides across which actually showed what things we had high confidence in and what we had, we didn't have high confidence in anything, what we had moderate confidence in and what we had low confidence in. So just drawing to a conclusion now, just to flag up a further opportunity that I had through my membership was to be involved in Cochrane's first ever rapid qualitative evidence synthesis. Now all the legwork and the filter work was done by the team at Evidence Synthesis Ireland, but through an existing collaboration, I worked with them to be their methodological advisor, and to essentially on a Monday morning I would get questions about the methodology and I would answer them straight away, so I didn't hold up the review. And that review took 25 days from protocol to publication. I'll say it again, 25 days from protocol to publication. Already on Google Scholar it's been cited 90 times, so I implied earlier that it was a choice between impact factor and WHO impact, but this review that was actually sponsored by WHO is hitting both of those targets simultaneously. And some students over in America have summarized this nicely in the form of infographics. So I'm not very good at creating my own impact, but I certainly appreciate it when people highlight the work that we've done in an imaginative and creative way. And on the back of that, I adopted 2 groups of medical students, 4 of them looking at panic buying in COVID, and 4 of them looking at the psychological effects of quarantine. They worked in groups of 4, and then each of those chose a separate review topic within the set of literature. So they would have 4 related topics that called the same literature, but they would have a specific topic each. And so here is just a selection of 5 of the posters that they produced as part of their output. And they did this activity as complete novices within a 6-week time frame, and I just marked those on Monday of this week. So to wind up, we've discussed different ways to impact. We started with the historical route, where you do a health technology assessment. We saw that the qualitative research was, if you like, buried as chapter 11 in this wider report. It took 24 years, and over that period of time, not to do you, I hasten to add, but 24 years to accumulate its impact, 298 citations. I highlighted the work for the WHO. It hasn't got any citations yet because it only came out last week, but that was published within 9 months. Came after the guidelines, so the review didn't feed into the guidelines in the sense of a published review. The guidelines were produced, and then on the back of that we were encouraged to publish the review that supported it. And then a third route, the rapid qualitative evidence synthesis, as already mentioned, nearly 90 citations done in a period of under a calendar month. But we're reflecting on impact. We might think of the model of the impact factor. We might think of the impact that we quite rightly take pleasure and pride from in affecting health systems, such as through World Health Organization guidelines. But real impact is really not about moving content from A to B, or by getting B to site A. It's about reaching the hearts and minds of students, and hopefully you can see the examples from the master's students and their country-specific reviews, example work that I'm now doing with my own PhD students, and these bachelor projects done by medical students, done within a period of 6 weeks, are always increasing the emphasis on qualitative evidence and how it manifests itself in decision making. So thank you for your attention. I'll now hand back to Claire, who's facilitating this session.
Okay, thanks, Andrew. Okay, we already have one question in the question box, so I'll read that. I think this related to the review you showed just a few slides ago, the one about healthcare workers, and I think it's about infection control. The question comes from Albert and says, would you say the utility of qualitative evidence in this case is to accommodate the perspectives of relevant actors who will be involved in influencing change and strengthening impact, or does it go beyond that?
I would say that's a great start, Albert, but I would say it does go broader than that. Obviously, the qualitative evidence gives equal voice, if you like, to all stakeholders. Once you have articles that look at, for example, when we were doing the work associated with Ebola, which was a sub-project alongside Zika, there were decision makers' views being captured in qualitative evidence, health professionals, but also it's to do with the implementation and feasibility. So I think it's also about easing the progress of implementation, hence the name of our Cochrane group, rather than just capturing the perspectives. So it's both retrospective in looking at what people feel, prospective in helping us to introduce things better, I think.
Okay, thanks, Andrew. Somebody else, sorry, Sadama has asked if you could share the perspective demonstration slide. I guess it might help to just track back to that now, but also I guess she's asking if there's any way that it could be shared more widely afterwards.
Yes, I do, and thanks for your questions to Dharma, but I'd encourage you to, sorry, for some reason I'm not, but I'll get there. But I'd encourage you to actually look at the article, which was quite an extended discussion of perspective. So I'll put that reference up. It was on the prior slide to that. So I do it myself. I find that the slide that has the reference on isn't the interesting one. It's the one after that, and then as you've just illustrated, need to put back up. So yeah, I'm working towards it. I think there's another question that you could possibly be asking, Claire, while I'm back to this.
All right, okay, sure. Yeah. Nima's asked, she's wondering about the appraisal of qualitative studies. Could you comment on this and which tools are most useful?
This is a real big issue at the moment. We did a review that was published last year that was that found over 100 different methods for appraising qualitative studies, and we came to the conclusion that when it comes to producing recommendations, which is what we're specifically interested in with Grade Circle, there wasn't anything that was directly suitable. We found that the most commonly used tool, and certainly a good starting point, is the Casps tool. However, there are a number of cautions, and we're currently composing an article to point out the limitations of using Casps for qualitative studies within a review. For example, Casps was designed to look at individual studies. It wasn't designed for use in reviews. So if Nima, what you to do is read a single article, then Casps would definitely be your starting point. If you're interested in synthesizing qualitative studies, then at the moment Casps is probably the least worst. We're working on identifying an alternative to that. Watch this space. It's called the Camelot project, I think.
Okay, thanks, Andrew. There's a few more questions now. Steve asks, he says, I think I missed something. Did you say how standard methods have been adapted to facilitate rapid qualitative evidence synthesis that can be completed in 6 weeks?
Well, I was probably speaking so rapidly that I don't think I probably did say that. It's a really good question. The guidance that has been produced there is actually by NHS Scotland, and it's available on the HTAI website. And if you have difficulty tracking that down, then do contact me. I can let you have that reference. My colleagues who were involved in that project on Evidence Synthesis Ireland have written an article that I understand has just been accepted for publication in Research Synthesis Methods on their own methods for that particular review. And I'm currently working with the Cochrane Qualitative Conveners on guidance on rapid QES, but that won't be published for quite some time. So for the moment, the NHS Scotland resource on the HTAI site is the best place to go to. Okay,
thanks, Andrew. We have a question from Lorna, who asks, how do we get over selective reporting bias in systematic reviews of qualitative research? The primary studies have already been selective in taking quotes, and a synthesis of many studies is going to be even more selective.
Yeah, I think the phrasing of the question is really good, because you phrased it as how do we get over it, and that has two meanings in English. It means how do we counteract it, or how do we handle it mentally. I rather suggest that the solution is most likely about how can we handle it mentally by realigning our understanding of what bias is in a qualitative research context. I mean, it's a really perceptive observation from Lorna there that it is an issue. what Grade Circle is trying to do by looking at the certainty associated with statements that are based on findings of qualitative research is to think of some of those potential influences. So looking for things like the coherence. So do the citations that have been chosen, are they supported by other studies? Are they internally coherent, or is it here that there is a dissenting view to a finding that seems to indicate commonality? Is the amount of data that we have adequate? So I think the answer actually involves not necessarily use of Grade Circle, but going to the framework that underpins Grade Circle and looking at those markers of good quality and asking those questions about the particular evidence base that you have in front of you. But just to comment as well that we formed a subgroup of Grade Circle looking at dissemination bias, and selective reporting bias is one thing that we've been looking at. We've found very few instances of it being studied though, so if anyone wants a topic to do a future PhD on, then that would certainly be a good starting point.
Sorry, finally, Layla asks, you mentioned the Camelot project. Would that be the Camelot tool?
Right, so the Camelot project has two phases. The first phase was to review the existing checklists to see how appropriate they are. And the second phase is then to select from all the items identified from the existing checklist to see what their empirical base was. It's work in progress, so very much the men at work or persons at work signs are up for that. We do have something called the Camelot plot, which is a wiki that's publicly available that summarizes what we found on each item of the qualitative checklist. So we're working through them one a month, and we review the evidence from qualitative research methods books, and we summarize the evidence, and we make it available in a wiki. And again, you can email me if you want to be pointed to that particular resource. But work in progress. Camelot will be, I imagine, the name of the final tool. We're hoping to deliver it sometime in the first half of next year.
Okay, more questions. Liam asks, as qualitative authors are being pushed to report their theoretical positionings, epistemology, ontology, etc., are there particular problems in aggregating reports with different theoretical underpinnings?
People are split on one, so it's a really good question. You tend to find that within health, we tend to be quite pragmatic, and so we tend to synthesize different qualitative research articles, and while we realize that there are dangers in doing that for the reasons that Liam says, we feel that it's important to provide some evidence to support decision making. And so even though it's questionable for that reason, we feel it is better than having no evidence. In education, they tend to take a very strict position and saying you should only combine information that comes from the same type of study. So, for example, that you would put phenomenological studies together, grounded theory studies together. So I'm afraid in health we have to be a bit pragmatic. We want to provide answers for the here and now. We don't do it carelessly. We're very aware of what we're doing, and I think it also links to the discourse I can see on the discussion board here on the chat, relating to people's own standpoint as well. We've just recently seen in the article from Sue Down that I referred to earlier, reflections on reflexivity and its importance for a reviewer. and indeed my student who submitted their assignments, after a discussion with them on Monday of last week, they all agreed to include a reflexivity statement for their own review with regard to their own attitudes towards panic buying and quarantine. So I think in the future, synthesizers, qualitative synthesizers, should be equally reflexive, an awareness of some of the issues that Liam is mentioning there.
Okay, Andrew, through the sort of direct messaging chat that's come to me, Lee Jinsun is here today, and he asks, could the selection bias issues be partly solved by using machine learning?
I mean, we've always been told there's two issues to it. There's the issue of identifying the data and then of labeling the data. The basic information retrieval problems, although Lee's in as a health service research student, so the first thing is, could we identify a complete corpus of research on a particular phenomenon? And secondly, when we go looking for it, could we find it? And those are upstream from some of the great work that that James Thomas and colleagues have been doing, that once it's clearly labelled as with words that you associate with qualitative research, how do we then retrieve it? So I think it's part of the solution, Lee's-in, but there are other things that we have to tackle first before we can stop processing it through these technologies. Great from you. See you for your supervision in a couple of hours' time.
Okay, I think that's all of the questions that we've had so far anyway. So at that point, I'm just going to switch back to my slides that I was showing earlier, just to introduce the next webinar that's coming up in the series. So for those of you that have joined us for many of these, you'll probably already know about this, but for those who are new to the masterclass series, we've got more of these booked in. Our next one this year, our last one for the year in December, is by Colin Angus. His session will be about visualizing the COVID-19 pandemic. His Twitter handle is @victimofmaths, and it's well worth having a look at his Twitter feed in the meantime, because he publishes numerous visualizations certainly on a weekly basis, if not a daily basis, about the work that he's doing. So that might be good prep for our next webinar. The first one in January will be by Professor Stephen Walters of SHA, who'll be talking about clinical trials. And if you want to book for Colin's session in December, the link is on the screen there for you. We'll get a joining link for Professor Stephen Walters as soon as we can, and we'll be publicising that via Twitter as we usually do. So many thanks for joining us today. There's links on the screen here as well about any inquiries about our postgraduate taught programmes here at SHA. There's a link on the screen and also an email address, shatu@sheffield.ac.uk, that you can use for pretty much any question about any of our programmes. So thanks very much for joining us today. This has been the most popular one of our mini masterclasses so far, by far the busiest, and thanks very much for all your questions as well.
Thank you, everyone, and I'm happy to have email contact with any of you afterwards if you.